Thank you, Mr. Chairman, for holding this hearing, and thank you to our witnesses for being here today. I saw a lot of head shaking yes when Dr. Murphy was talking, and I'll come back to that in a minute. Representing a state like Oklahoma showed me how fractured our healthcare system really is. Rural patients have trouble finding specialists who are nearby or feel a primary care appointment is not worth a 2-hour drive. A couple of years ago, I saw something incredible that the Oklahoma State University Medical School is doing. It was a great answer to these problems. Their medical school has collaborated with their extension programs to offer the great folks of Oklahoma mobile virtual care vans. The focus of the OSU mobile care program is to, quote, concentrate on non-life-threatening conditions like common illnesses, chronic disease processes, and minor injuries with the goal of providing accessible care to rural communities of Oklahoma. They focus on chronic disease management such as diabetes, high blood pressure, and simple medication refills. They also treat minor injuries with preventive infections and keep people out of the emergency departments. In addition to on-site treatment, the staff can connect patients with primary care physicians if they do not currently have one. This helps ensure patients have ongoing trusted relationships for follow-up care. Navigating the healthcare system can be a considerable burden for many patients, so having a professional there to help ease this burden helps dramatically. The success they've seen goes to show how vital telehealth and mobile health is for our rural communities. My colleague, Congressman Moylan from Guam, was just telling me the other day about how telehealth is so important to our territories. I'm incredibly proud of OSU and Director Jared Droz for being innovative and meeting Oklahomans where they are. And this is just the type of care I think needs to be applauded and expanded. Dr. Hoban, what benefits have you seen for patients and the local health system when communities have access to mobile health clinics?
Thank you for the question. I think what you describe is exactly right. Lack of access creates poorer outcomes when it comes to chronic disease management. And so the telehealth opportunities, the mobile opportunities, the quick connectivity to both primary care and specialty care through those easier access venues is where we will land on better outcomes and reduce costs, because we're decreasing the complications and the emergency care versus more the chronic prevention care.
I appreciate that. My colleagues on the other side talked about the promise that Republicans, Donald Trump, made about lowering health care costs. I wonder how that lays in comparison to the promise in 2010 with Obamacare, where you could keep your doctor, health care costs would be lower, access would be greater, and since that time we've had 80% increases in health care costs. Doctors, second-generation doctors, are no longer going into practice because they can't afford the medical school and the payment afterwards, so they go to work for hospitals if they stay in the business. We've had some 150 hospital closures since then, all of these prior to the One Big Beautiful Bill. But it's also interesting, some would describe that as reckless, when many people, as Dr. Murphy, who practices every single day, would tell you that anytime you do that, you're going to have a real problem with your healthcare system. And just as they predicted, here we are today, trying to figure out through patchwork to make this a better place. I would like for anybody to answer this question, because I think there's been a real convolution of the message when it comes to premium tax credits that nobody seems to want to delve into. But you say that people are going to lose health care costs, Mr. Connell, or health care. There's 168 million people on employer health care plans. Does the premium tax credit help lower their costs at all?
The premium tax credit only goes to folks who are buying plans on the marketplace, not folks who are getting coverage through their employer.
So just for the record, when you see your plan go up as mine did, because I don't do anything with the government, I still have my private plan from being in business for 35 years, and I pay 100% of it. And so Kevin in Oklahoma, as you described, Susie in Wyoming or whatever, Kevin in Oklahoma, my monthly premiums are going up $500 a month. And so the premium tax credits do nothing for me, correct?
The premium tax credits don't go to people who are on employer-sponsored sponsored insurance.
So I think that's important to note, right? I mean, almost 170 million people that have a plan with their employers will see increases in their plan because of why? Because the underlying health care costs are exorbitant on a per-patient basis. We spend more on a per capita basis in America than anywhere else in the world. I think everybody would agree with that. And so we have an underlying responsibility to lower healthcare costs for all Americans, not just 2 million or the expanded COVID relief, that the news from my Democrat colleagues is COVID is over. They're the ones that set the 2-year expiration at the end of 2025, not us. And they're asking us to extend what they thought should expire as well. And so we're going to work together, assuming our Democrat colleagues want to work together, to try to figure out how to lower health care costs for everyone, all Americans. We all work for all Americans, not just a sliver. I yield back.